Thanks. Good morning, everybody. And thanks for the invitation to give this talk, Informed Consent, Why Do We Care? I was given the title. I'm going to change it slightly to Informed Consent, Why Ought We Care? I'm not convinced everybody in the world cares about informed consent, but what I'd hope to convince you is that we ought to care about it. It is my favorite enzyme. I love this enzyme when it's done well and right, and it can be awfully fascinating, but it also confuses lots of people along the way for lots of reasons. So what I thought I would do is this may be very familiar to some of you. Some of you may have given this part of the talk about how we got to this notion of having informed consent being part of research in healthcare. Some conceptual arguments about two senses of informed consent, and then I want to expand that view slightly. So that's the philosophy before 9 o'clock in the morning. So seatbelts on, please. And then talk about informed consent as a process and what that means. And a lot of people talk about that, but also there's a lot of confusion and confounding over that. And so I'd like to say what that really means in practice to meet the ethical goals. That's a lot to accomplish. I would normally do a seminar on this, so here we go. So we tend to use consent today for both medical treatment and research. They evolved separately, but we've been left with sort of a similar process. For medical treatment, informed consent evolved largely through patient litigation. Doctors did things that weren't so good to patients without their permission, and litigation resulted in a variety of court cases, which then led to legislation and regulation regarding what should go on. For research, there were early consent practices that evolved because researchers thought it was important, and then there were a whole bunch of scandals, which we're not going to have time to dig into too much today, but it's easy enough to find information about those. So let's back up to the turn of the last century. Early in the first decade of the 20th century, a woman named Mrs. Schlowendorf goes into Cornell Medical Center. She has a huge abdominal mass. She wants to know what's causing the huge abdominal mass. She's postmenopausal, so it's not pregnancy as the number one cause of abdominal mass in a woman. So what do the doctors order in about 1906, 1907? What do they order? What test? MRI? CT? Ultrasound? No. X-ray? Sure, we've had them for about 15 years, and it showed gray stuff. Not much. So what did they do? Well, they got permission to put her to sleep, anesthesia, so that they could figure out what was going on. And what happens in anesthesia is there's relaxation of the abdominal and pelvic musculature. You can actually do an exam under anesthesia, and if you're trained in how to do this, you can pretty much determine what's at a tumor or something else. They thought when they did the exam under anesthesia that Mrs. Schlowendorf had fibroids of the uterus. Reason why I'm using that, those are actual terms used by patients, malapropisms and slang. So she had fibroids or fireballs, and the doctors sitting there had her asleep and said, you know what, she's asleep, let's take this out. Well, fibroids are a benign tumor. They don't need to come out. Think about an operation in the early part of the 20th century. We don't have antibiotics yet. We don't have suture manufacturers. We use catgut sutures. We have long abdominal incisions. Recovery could be 6 months and can be dangerous. They took out Mrs. Schlowendorf's uterus. She woke up, and in New York parlance, she was pissed, right? So New Yorkers being New Yorkers, she sued the doctors, right? She said, listen, I gave you permission to tell me what was wrong, and you took my uterus out. Not good. Justice Cardoza, famous judge, says this very strong statement. Every human being of adult years and sound mind has a right to determine what shall be done with his own body. So he had part of the facts right. And a surgeon who performs an operation without his patient's, he was correct in this case, consent, commits an assault for which he is liable in damages. That's a very strong statement. A very, very strong statement that begins a cascade of court cases in which consent has to be obtained, and gradually consent has to be informed. I'm not going to go through the series of cases. Lots of cases are messy. Every state passes a statute for healthcare requiring consent for medical practice. Whenever the medical profession was not good about particular features of consent, when things were risky or scary, legislatures jumped in to provide additional rules and regulations. Up until recently, for instance, every state has a separate statutes about consent for HIV counseling and testing. Virtually every state has statutes regarding consent for abortion, separable because of the moral decisions around it. Several states have ECT regulations about consent. And the court cases work around, if you look at most of the abortion laws, they come around issues of consent, too much, too little, and the like. Now, in research, this was a somewhat different setting. Early on, researchers realized if they were doing research with volunteers, that they needed to get consent. You couldn't just come up to somebody and say, hi, let me have your blood, without getting some kind of consent. You have to say, what's that for? It wasn't necessarily free and voluntary. So the famous case that's given is Walter Reed's famous yellow fever experiment. Walter Reed wanted to figure out what was causing yellow fever. It wasn't known that the mosquito played a role in yellow fever. The Army was interested in sorting out infectious diseases because up until the Vietnam War, or if you're Vietnamese, the American War, figured out that infectious diseases killed more people in war than any kind of armed conflict. So the issues were this was killing our troops, and so right after the Spanish-American War, also about 1906, Walter Reed says, yellow fever happens in places that are hot, like Washington, places that have mosquitoes, well, like Washington, but also like Cuba. And he says maybe the mosquitoes play a role in yellow fever. So what he wants to do is he wants to take a mosquito, have it bite someone with yellow fever, and then take it over to a volunteer and see if it bites the volunteer, whether the volunteer gets yellow fever. Clear way to show the mosquito plays a role. Turns out he was right? So the research was necessary to sort that out. It could have been lots of other things. It could have been sand. It could have been palm trees, coconuts, papaya, mango. Who knows? But it was the mosquito. And now it seems obvious, but you didn't know. In order to do this to people, he needed to get their consent. He did these in Cuba following the Spanish-American War. He got written consent in 1906. No institutional review boards, having to do this. He got written consent, English and Spanish. And it was witnessed, 2 witnesses. No rules. He just thought that that was the appropriate way to go. Now, his consent process wasn't perfect. If you participated in his experiment, you got $100 in U.S. gold. Now, post-war Cuba in 1906, that was a ton of money then. It's a ton of money today. I don't know what happens. I put plastic into a machine in the wall of usually banks, and out comes paper. Gold, U.S. gold, $100 in U.S. gold. I haven't seen it. I heard it's in Fort Knox. I don't know if anybody's seen U.S. gold. Sounds pretty good to me. If you got yellow fever, you got $200 in U.S. gold. So a little bit excessive in terms of compensation. And, the Army was running this study, and you weren't allowed to withdraw. So, again, not perfect, but the notion of getting consent was there, but the free and voluntary point wasn't emphasized. Okay. Oops. Go. Next. Thank you very much. No. There we go. So let's think now about why we do this. Now, Ruth Faden and Tom Beecham marked out many years ago a conceptual model in which there are 2 senses of informed consent. Sense 1 is autonomous authorization, and sense 2 are the social rules of consent. Autonomous authorization goes to this idea that was based on the ethical principle of respect for persons or autonomy, the right to liberty or the right to be left alone, that political principle. So embedded in all those court cases and those things about these notions about if we don't want to be bothered in our, say, personal lives or our political lives, this country founded on liberty, right? Life, liberty, the pursuit of happiness. Everybody got that one? You tax us, we throw your tea overboard. Don't touch us. Why would it be surprising that in the healthcare setting, all of a sudden, we would like to be touched or have things done to us without our permission or consent? So this notion of liberty, the right to be left alone, is really central to who we are, at least in the West and the North. But then even in the South, there are no nations that like to be controlled by other nations, right? So this idea about being left alone is really critical to justifying what it means to make our own decisions and to give consent for research or the healthcare setting. It is a powerful construct. Now, it differs culturally. As you know, if you've traveled internationally, the British are a little better than us at keeping a greater social distance. You know, they can just be really, hey, nice to see you, sorry, right? We're pretty far apart. If you meet someone in Latin America, the rest of the world, they'll hold on, they'll hang on for a long time. Worked as a doctor in Tanzania, all through rounds they'd hold my hand. Really warm. Our social distances differ, but we all have notions of what it means to be respected and to be left alone and the right to liberty. We often get confused. There are people who like these social rules of consent. There's special rules with consents of minors or special forms or witnesses, things that are put in place during consent processes and regulations about consent processes that remind us to do a good job, but in and of themselves, they're inherently not interesting. I'll just say that. They are there to serve as a reminder to meet the ethical goal. People get tangled in all the elements of 45 CFR 46.116 and how it's documented under 45.117 and 21 CFR 50 has different requirements for documentation. Great. I'm glad you know that stuff. It's there. Follow the rules. They're there. But they are there not in and themselves to be important, but to meet that ethical goal. Now, I want to expand it slightly because I think that the conceptual models for consent don't quite capture all the things that happen in an informed consent process and why we ought to care. Of course, we have this idea of respect for persons or autonomy. It's one of the central elements of ethical theories. It is important and critical on its own. Liberty, essential as a political construct, as a legal concept. The things that we just don't have things done to us without our permission, again, central. But there are additional considerations of why consent matters. It's become sort of that common pathway that we need to accomplish a lot of health and non-health related goals. For instance, welfare. I may have evidence-based be practicing evidence-based medicine for something, and there may be 2 alternative treatments which I could prescribe for an individual patient. To me, it doesn't matter, but an individual patient may know something special about herself or himself that could change, say, a side effect profile. They may know that they can't afford a particular approach. They might not like a particular approach because they know that it's not good for their well-being. That they know that if any pill makes them nauseous at all, they're not going to take it. Or they may know they're a lifeguard and they have to go in the sun, and the idea that you say you can take this medicine but stay out of the sun, it doesn't work, right? So there are these welfare considerations that go beyond our typical evidence base. There are also non-welfare-based considerations that go in. I may have moral objections to different approaches. I may have a moral objection to, say, the use of a human embryonic stem cell line to help treat something because I don't agree with the idea of destroying an embryo to create a treatment that would be life-saving to me. There may be group identity harms, things that harm my group as people. I may be concerned about distribution of benefits. Transparency is another reason for the behaviors or whatever we're engaged in, whether it's healthcare or research, that there's this call for transparency about what's going to happen to me or to you. And finally, the notion of trust or participation. We know that trust is central to participation in research. And if we don't create a trustworthy system, we're not going to engage enough people in a trusting system. So unfortunately, consent's been the place where all this is taking place. None of the federal regulations are going to capture this, none of the guidelines about it, and the conceptual models are poor here. You can see that some of these things are related to literacy and other things are not related to literacy. So if you heap on literacy concerns on parts that are unrelated to literacy, that may not be a good use of effort. Not everything is about understanding. Okay? The whole process isn't about understanding. Part of it's about these other features. And that's important to keep in mind as you craft your recommendations. So let's get to the process. In order to meet these ethical goals, what do you need to do? So first of all, informed consent is largely, although not completely, a conceptual task, a cognitive task. So we think of it as a cognitive task, but sometimes when we're obtaining consent, people have already made a decision to participate in whatever it is, and you have to push them away. In other times, you're enticing people in the process of getting consent to participate or to do something you believe is in their interest or in the interest of a researcher. But let's assume for a moment that there is at least a cognitive element to this. There is a big cognitive element. And in order to play that game, you have to have decision-making capacity or competency. And what does that mean? Can someone who's using a psychoactive substance give consent? I Anybody in here using a psychoactive substance? I am. How many people have coffee? You people are not participating, see? Look at all those coffee. I mean, I'm sure it's all placebo, right? Everybody's got decaf. Okay, I have some too. We're going to take a break later because coffee has other effects. But this idea here, right, of a psychoactive substance is not the answer. Some psychoactive substances, like the 20% of Americans who at some point may use an antidepressant, may be better positioned to make an informed decision. The first-time user of crack, probably not, right? So the idea is, what are you trying to accomplish? What does decision-making require? What capacity do you have to have? In short, you got to be able to take in new information. You got to be able to process that information. You got to be able to use that information. You got to be able to make a choice and express that choice, right? So you've got to take in this new information that you have not probably seen before, although in some situations, patients may know more than their doctors or the person obtaining consent for research because they've done all this research before they show up. So it's not always information giving, sometimes it's information correcting and the like. So you have to have decision-making capacity. All right. It's not just intelligence either. Think of Rain Man, right? Rain Man could take in lots of information. He could read all those decks of cards in Vegas, right? This is when we liked Tom Cruise. Remember we liked Tom Cruise back then? And it's before he jumped on Oprah's couch and he's sweating the right places, good-looking guy, taking his brother, right? Takes him to Vegas. But Rain Man could make a choice. Now, Tom Cruise wasn't making the best choice, teaching his brother how to bet, right? Or keeping away from Qantas or Time for Wapner. But he was at least showing you the difference, the ability to take in information, be very smart, and be unable to participate meaningfully in a consent process. Now, you might question whether Tom Cruise could take place in a consent process based on his recent behavior. See, his behavior is intermittent, fluctuates. All right. The next is you've got to be positioned to make a voluntary choice. This is the threshold, right? If you don't have decision-making capacity or competency, you're not positioned to make a voluntary choice. All this other stuff doesn't matter. Doesn't matter. Here, I'm going to give you an example of voluntariness. We always say informed consent is voluntary. I was giving a talk on informed consent to a group of people who obtain consent all the time. That's their job. And there were a couple thousand research assistants, research nurses in a room. And a woman said to me, Dr. Sugarman, I can never get people to sign the form. Said they can't sign the form or they won't sign the form. Oh, they can't sign the form. So, well, tell me what you're working on. She said, well, I work with this anesthesiologist, and she always does phase 3 or phase 4 studies because she's trying to practice evidence-based practice. We're always comparing all these known agents to one another, and they're all used in practice, so it's good for us to do that research, right? I said, well, tell me a bit more. When are you obtaining consent? She said, well, in the pre-op holding area. They're always there. Now imagine the situation. You're about to have surgery. You're naked. I will not demonstrate. You now are naked. You have a thing they call a gown, which is like the thinnest veil you've ever seen in your life. It's over you. Your butt is colder than it's ever been. Your arms are tied back because you've got 16 gauge IVs. Those are big ones in both of your arms. You're tied back like this, okay? Naked, little, don't take a picture of that. Naked. Just see, I got that. He's already got it. He beat you. He beat you. She beat you. So you're back like this, and this research assistant comes in. She goes, looks down and says, hi, I work with your anesthesiologist, the person who's putting you to sleep. You haven't met her yet. You'll meet her in a little bit. We're doing research. Do you want to help us? Now, she was worried that they couldn't sign the consent form, right? She had an IRB-approved consent document. You couldn't sign it because her arms were tied down. That's what she was worried about. I'm worried about why was consent done there and how voluntary was that choice. Now, none of the federal regulations tell you do not approach people who are naked, cold, scared to be, and they're about to have surgery. Think about it when they're dressed. The rules assume competency or capacity and your position to make a voluntary choice. That's the critical ethical piece of when you're going to obtain consent. Okay, so again, if you're not in that position, these things matter a lot, and you can imagine other situations that impair voluntariness. Now, finally, you give, if you do have someone in that situation who's gotten over the threshold, you can give them information. And you want to give them information about what's going to happen. And here the federal rules are pretty good. What's going to happen? What are the risks, the benefits, the alternatives, procedures to be followed, Who do I call if something goes wrong? Who do I call if I have questions about my rights and interests? Will things go confidential? And other information that may be relevant. It's all the information you'd want if you were being asked to give consent. Now, the trick is you need to do it in a way that is understandable. Mrs. Schlondorf had her fireballs of the Eucharist. Some people have Smiling Mighty Jesus, spinal meningitis. Some people's children are so sick as they have sick as hell anemia. Some people have very close veins. Other people get sick, and they're very sick. They get taken to the intensive care unit. Now, each of those malapropisms are things that we actually heard. I am not just making these up. When I was a medical student, I had my classmates write down all the malapropisms we heard, and we published them. Now, if you hear a malapropism and you're involved in healthcare, write it down, send it to me. But then use that moment to explain to the patient what might be going on. I understand you might think it's called sick as hell anemia. Why would someone know what a sickle cell is anyway? How many people know what a sickle is? You don't have to raise your hand, right? So I know it sounds like that, and I know your baby's very sick. The reason why we call it sickle cell anemia is because blah, 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 blah. And you do a job of translating those medical terms. We've also done some empirical work for the White House Advisory Commission on Human Radiation Experiments, where we found that the very terms used to describe the research process have different denotative and connotative meanings to the people involved. So the word experiment is risky, scary, you don't know what you're doing. The word study was the enantiomer, the mirror image, the complete opposite of experiment. The word study meant the doctors are going to study up on you and study up on your diseases. That's not like a phase 1 study, toxicity study. So if you can describe all the medical terms but not describe the research process and what's happening in this research project, is this a survey or is this trial of a first-in-human study of a drug that's never been tested and we don't know what's going to happen? Those are very different things. Very nuanced differences that matter completely in people's understanding of what's going on. So in order for informed consent to be obtained, you've got to give information in a way that's understandable. Finally, you get to this situation where you give them a consent document. We give people precious little in the research process. You get your HIPAA authorization form when you get into a healthcare system. But the question is, what do you get? You get a consent document to look at. And one of the things that I like to do, sorry to go off mic, is if I'm giving a consent form to someone, I give them the consent form, and he's just going to, oh, you know the trick? Yeah. Do you know the trick? Okay. He didn't know the trick, but that's good. Okay, so perfect. What did he do? He turned it around to look at it and read it. I always go to people with glasses, so I want to make sure that even if he knows the trick, because I don't know. Sometimes I forget mine. I can't read. So, I don't know who I stole that from. Is it here? No. Told you I needed these. So the issue is when you're giving a document to people, again, this is not in the federal rules. Surprise, surprise. Give them the form upside down. If they read that language and they have their glasses and their eyes haven't been dilated by the eye doctor or whatever's going on, they'll typically turn it around and look at it. Don't have to say, can't read. Right? The issue, the simple task of saying, while you're looking at that, so take a minute, go do something else, read it, circle it, write on it, ask me whatever questions. Perfect. If they keep it upside down and backwards, which I probably would do if you gave me a Cyrillic consent document. I love looking at Cyrillic consent forms. They're beautiful, but I can't read them. I want you to read that to me. But so you can simply say, while you're looking at that, I'm going to read it to you. Stop me if you have any questions. So the look of giving the document, giving it over, it should be consistent with the disclosure. It should be readable. People use them later. They use them to look up all the things they were afraid to ask, forgot to ask, as a reference document. And so the documents themselves are doing a lot of things besides being the be-all that ends all in giving information. So what I hope I've shown you is that respect for persons is manifest in the expectations of a meaningful informed consent process. There also are a set of other ethical constraints that are caught up in this social process of consent, and we ought to care about consent. Thanks for your attention. It's going. There we go.